And they're slowly joining in. We will give everyone a minute to gather from the waiting room. While we are waiting, I'm wondering if I could get a thumbs up or a quick high five to let me know that the sound is working okay on everyone's side. You can hear me. Thank you, Terry. We'll just wait a few more minutes to let people roll in. And if for some reason your sound is not muted, can you please double check that it is, just in case there's any background noise? Okay, I think I might just go ahead and get started. There's some people that I'll let in as things get going. Sorry, I'm tripping over my words. I would like to take this opportunity to welcome everyone to our lower extremity lecture. Thank you very much for taking the time to join us. My name is Renee Westmacott, and I am your host for the evening. I'm here for any questions that may come up during the lecture. In the event of a question, please feel free to write them into the chat box. If the question is relevant at the time, I will ask the question for you. If not, we will wait until the question and answer at the end. Please let me introduce Dr. Kurt Whitney. Dr. Kurt is one of now for many years. I'm going to get this wrong. I know I'm going to Western States University in Portland, Oregon. And as a former soccer player, Dr. Kurt has extensive knowledge of injuries and how they can affect day-to-day activities as well as one's mental health. Dr. Whitney is certified in active release therapy and functional movement systems 1 and 2. In his practice, Dr. Kurt is focused on soft tissue treatment, spinal manipulation, and rehabilitation. If everyone can please join me in welcoming Dr. Kurt Whitney. Welcome. I'm passing it over to you.
Cool. Okay, thanks for coming, everybody. So yeah, today's lecture, for the most part, is gonna be, am I muted or am I good? Okay, I'm good. Okay. So yeah, for the most part, is gonna be just talking about the lower extremity and how kind of like when the hip and the knee and the ankle and the foot itself, what happens when one system is not working or when multiple. So yeah, we'll just kind of jump into it. Sorry, excuse me. So let's go. There we go. So yeah, this is me and my dad when I was in. We went on a little trip to London. So yeah, as Renee had already said, graduated UBCO in 2015. That's where I got my undergrad. Was a personal trainer at the Glencoe Club for 2-3 years, and then went down to Portland. Graduated summa cum laude with my doctorate of chiropractic. So yeah, that's a little bit about me. And yeah, played a lot of soccer. Clearly, I'm an Arsenal fan. Yeah, if any of you aren't, don't hold it against me. Okay, so quick, we'll get into it. We'll kind of touch on just brief anatomy. So Renee said that you guys can see my cursor, but I guess there's a pen that I can use. Give me a second. Let's see here. Nope, that didn't work. Laser pointer. There we go. Okay, so obviously this up here, that's our hip bone. This is the hip joint itself. So we have the femur right here. That's the thigh. the hip itself, like this big section there, is made up of 3 separate bones. But for simplicity, we're just going to say that is the hip. Then we go down to here, we have the tibia connects to the knee, and then the ankle itself. And then out here is the fibula, which is another important bone. And then we get into the foot itself again, which makes into the ankle, obviously. So yeah, you can see here kind of the way that the joints are set up, that they look kind of inherently like they're going to have more motion in certain ones. The knee itself, you look at it, it looks like it's almost in tracks, like the different condyles, which those are the lumps right there in the knee joint. Those are the condyles. So those look like they almost sit in a track. So they don't really do much. Obviously, a knee doesn't do much besides hinge back and forth. So that's our flexion and extension. The ankle itself, again, looks pretty similar. It looks like it's in a bit of a tracking system, but it actually will kind of tilt to the sides. It's not a ton, but it's pretty subtle. But the hip, it looks like a big teacup, right? Like, and you're putting a ball in a cup, like it's a big joint. And traditionally it's known as a ball and socket joint, so it kind of fits. So that's going to have a lot of motion. So just from that, we're going to look at the foot itself, which has very little like it has a lot of joints and a lot of bones in it, but the intrinsic muscles, the little muscles that make up the foot itself, those stabilize the foot. The ankle is pretty mobile, has lots of different ranges of motion and different things that it does. The knee, like I said, pretty much goes straight back and forth. There's a little bit of rotation in it, but not very much. The hip has tons of ranges. It has to be able to move. It's our main thing that really set us apart from, like, in evolution, was the fact that it allowed us to be bipedal. So walk on 2 feet. So yeah, that's a quick intro on the anatomy. I don't want to go too far into it because I'll end up talking about it for half an hour. So next thing, we go into the hip movements. So this is where we're going to kind of touch on these so you guys get a basis of like what is going on with the hip when we're going through ranges of motion and certain things, and also what we do when we're testing these things in the clinic. So flexion, think of it as like decreasing a joint angle. So the hip is going to come up like this towards like a 90 degree. I'm going to make this way easier. I have my trusty skeleton beside me. Okay, so we have the hip here. Let's see, quick little turn. We have my hip. That is flexion. Obviously, we had a little bit of knee flexion there too, but flexion. Extension is just going to be going backwards. Scully here has really good extension. So the next thing we're going to do would be adduction. So that's, we're adding to the midline of the body. So we're going across like this. And then abduction, we're taking away from the midline of the body. So we're going out like this. Then we're going to have our internal rotation. So think of it as like which direction the kneecap is going or the feet. So if I internally rotate, the kneecap and the foot are going to transition towards the midline of the body. Externally rotating, we're going to go outwards. Okay. So that covers those ones. And then we're looking at circumduction, pretty much what it sounds like. It's making a circle with the hip. Okay. Get sliders for my chair, apparently. Okay. Then we were going to move on to the knee. So again, like I said, the knee's pretty simple in what it can do. It flexes. Oh, I shouldn't have switched this back so soon. I jumped the gun. So the knee flexes and it extends. Okay. Pretty simple. Again, there is a little bit of internal and external rotation, but it's pretty minimal. So again, the internal external rotation of the knee is going to be virtually the same. It's the same, well, not virtually, it is the same concept as the hip. So this big bone on the front of the tibia right there, if that tilts inward, that's going to be internal rotation. If that goes out, it's going to be external. Pretty simple. Okay. And then our next one, we're looking at the ankle. So this is going to encompass both the ankle and the foot. Let's see if I can get this up here. So we have our foot. So dorsiflexion, and this is where the ankle and doesn't really match up with a lot of the other like joints of the body, in the fact that they have like specific names just for the foot that are actually, and same with the hand, that are the same kind of movement as you would have like flexion, extension, which are pretty intuitive. But the ankle, they make it a little tough. I don't know why. I didn't make it up. So dorsiflexion, think of it as the top of the foot going towards the shin. So like this. This is a super, super key motion. We're going to get into it way further as we kind of progress. I just want to give you guys like kind of a basis of when I say certain things, what I kind of mean. And then we're going to have plantar flexion. So that's going down. Okay. So we're moving the foot towards the plantar surface. The plantar surface is the underside, the bottom of the foot. Yeah, so then we have inversion. So think of in going towards the body. So we have that one, okay? Then we have eversion. So again, if this is the bottom of the foot, this would be the inside of the body over here, bringing it out. That would be our eversion. So this motion clearly has like, or not clearly, it's much more difficult to create that motion. Even if you're trying to do this at home, this one should have a lot more range than this one. It should be pretty tough. The fibula on the outside, the big bump in the bottom of the ankle there, that pretty much gets in the way. Adduction is your interrotation. So think of that one again as just rotating kind of the ankle in. So we're not turning it like that. We're just moving the toes towards the midline. And abduction, again, the exact opposite. We're going outwards. Okay, so we're abducting away, we're adding to the body. Pronation and supination are the tricky ones. So pronation, I'm going to put this down because I'm not going to be able to demonstrate with him either way. So pronation itself, and a lot of people, like if you attended the foot lecture that I did over the last summer, I think we went into this in depth, but if not, we'll quickly touch on it again. So pronation, think of like the foot as it has the arch, right? So we have the arch of the foot outside, this is the inside. When we pronate, we tend to collapse in and down. So the arch of the foot goes away. So if you're somebody who has like flat feet, but when you're standing, but when you take your foot off the ground, you develop an arch, you're somebody that might really benefit from training the foot itself, not just the ankle. So yeah, that would be our pronation. So when the foot goes flat, supination is when we come out to the sides. So if this is again our foot, we have our nice arch right here, outside of the foot, and then our toes, we're gonna go like this. So we're actually gonna almost like bring it around to the side. So then when you step, you roll on the outside of the foot rather than continuously and toeing off nicely. Yeah, so those are all our motions. Again, really quick. Want to get to the meat and potatoes of it all, not just the veggies that we're going through right now. Okay, so the joint by joint approach. This is kind of where everything comes together as far as joints, and then there's other things that link all the muscle and all of that aspect. But this, with relation to kind of what we're talking about, is one of the most important and like substantial models that's kind of come out in the past close to decade with relation to like rehab and how to look at things more holistically rather than just focusing on where the pain is. So yeah, so the body is a series of joints going from stable to mobile. So stable joints tend to be stacked, and then mobile, stable, mobile, and they work their way up. So you can kind of see here, the yellow circles are the stability circles, red are the mobile. So the foot itself, like I said, should be stable. The ankle should be mobile. And then we work our way up. Knee is stable, hip is mobile. Low back is stable, thoracic spine. So the mid back is mobile. The neck itself is relatively stable. And then we get into the base of the skull, and that's where we see some stability or some mobility. And we work our way out to the arm. So we're not going to touch too much. We're not going to touch it all on any of the arm or like kind of upper back stuff. I will briefly mention the low back just because it plays a huge role with the hip. But yeah, for the most part, we are hanging out in this region. So yeah, like I said, the foot's stable, ankle's mobile, knee is stable, hip is stable, or hip is mobile. And again, that kind of matches with our joints, like I had said. So to give you like kind of the overarching definition of what they say stability is in this situation, it's the ability to maintain a position while that joint or the joints around it move. Mobility is the ability for that joint to move freely without a restriction in a full range of motion. Yeah, so that's pretty much the joint by joint approach in a pretty quick and dirty way. Yeah. Okay, I'm gonna actually say that real quick before we kind of move on. Are there any quick questions or any questions about this? Because everything's pretty much going to be expanding on this section.
I don't see any on my side.
Okay, cool.
No, one question about Scully's diet. Is it dehydrated food or is he on like low fat?
Yeah, he does keto, I think.
Oh.
I think that's what I found out. We had a quick chat one day about his diet because we're all striving. But yeah, I think he said keto. I don't know. Okay, so we're good on this one. Again, it's not the most difficult concept, but okay, cool. We will move on. So the foot to the ankle. So this is kind of where we're going to get into. Oh, give me a sec. Hold on. I got to move something on my screen. There we go. Okay, cool. So, oh, now I'm clicking buttons. There we go. So the foot itself, like I've said a few times here, is a stable one. It's made up of multiple bones. The muscles inside the feet are what create the stability. So when I was talking about the pronation, if we have an issue where those muscles are weak, that's when we'll see that flat foot happen. And again, that's a flat foot when you're weight bearing, but it goes back to like what a traditionally normal foot with a nice arch would look like when you're not weight bearing. If you have flat feet and it's flat when you're not weight bearing, this is not you. This more than likely is not going to help. At least like for pronation, like training the intrinsic muscles of the foot. So yeah, that's kind of the big thing there. The ankle, like I've said again, it's meant to be mobile. Lots of different ranges of motion, even if they're subtle, they need to happen. The big thing, and this is again one of the most common things that we see, is people lack dorsiflexion. So like I said, that dorsiflexion is when the top of the foot goes towards the shin bone. So if we're walking and we don't have the ability to dorsiflex fully, what sometimes happens is that we end up swinging the hip around. So we're swinging the whole leg to bring it around to the front. So just even thinking about that motion of like, okay, instead of me translating my legs like this, all of a sudden this leg has to swing, this leg goes straight, this leg swings around. That's a lot of motion that shouldn't be happening repeatedly. So that's where it might not be a problem short term. So if you have like, let's say you sprained your ankle and now you have that little bit of issue, you're not dorsiflexing quite enough, but that only lasted like a month. That's a month of repeated trauma to that leg and to the other leg, because now the other leg has to compensate for a lot of those situations, potentially by hiking that hip, or you hike the damaged ankle up, that other hip has to go low to bring you into that situation where you can swing that leg around. So yeah, that's where dorsiflexion is huge. Plantar flexion, so that toe off portion. If we don't have all of that, we're toeing off rather than from like the balls of the feet, we're toeing from like midfoot, which isn't efficient in our movement. So those are they're key in reality. Dorsiflexion again is probably the biggest one that you're more than likely to see in a lot of situations. And yeah, that's if you run, if you're a walker, you are a weightlifter, there's a good chance dorsiflexion. If you're having pain in your knee, hip, low back, dorsiflexion is probably playing a role somewhere along the line. Again, main reason with the foot being the stability point, the shoes that we tend to wear are pretty narrow. So we're not allowing those intrinsic muscles to do their job. So we're relying on the shoe. So then when that happens, the shoe's not stable. So then the foot is narrow. So if we don't have that big toe out to stabilize the foot, then we're more likely to pronate. So again, if we pronate, then when we pronate, we don't dorsiflex as much. And then the knee will cave inwards. So that's called a valgus. And then from there, we're likely to be putting strain on to like the outside portion, the lateral muscles of the hip. And then the medial portion is the inside portion, like the inside muscles of the knee. So yeah, that's, and again, we're pretty much gonna kind of rehash that same thing, just with a focus on like the different areas. But dorsiflexion, like I said, is probably one of the first things if someone comes in with knee pain that we're looking at. If we've looked elsewhere and we're not seeing any issues with like the hips or something like that, if they have hip pain, then yeah, the ankle is most likely our culprit. So yeah, it's a huge one. The feet are big, and it's kind of just coming to light how big of a role the feet and the ankle play in a lot of things. Yeah, so we'll keep going on. So ankle to knee, again, like I said, the ankle is meant to be mobile, the knee is meant to be stable. So this is, again, kind of just rehashing what I said. If the ankle lacks that dorsiflexion, so we're not able to get in that position, that causes the foot to pronate, to allow for more dorsiflexion, and then to further get into that range, the knee comes in. So we get that valgus force, which again, it's just puts strain. So we can get the kneecap tracking a little medially because the quads are pulling in a different manner than they normally would be. And yeah, it all becomes a big mess. All right. So yeah, that's ankle to knee. So not really, again, a lot of it's pretty similar. And if we have like someone has excess plantar flexion, or sorry, doesn't have enough plantar flexion, then that knee again tries to further flex to allow them to toe off, which is now further strain onto that on that knee joint. Yeah. So knee to hip, our hip is our mobile joint, knee is a stable joint, okay? So this is where, since the hip has so much mobility and should have so much mobility, this is where I'm gonna touch on two things, mobility and mobility, sorry, I feel like I slurred there a little bit, and motor control. So motor control itself is pretty much stability, but it's the ability for you to control the joint or control the limb that you're moving effectively through a range of motion. Stability or mobility is just like, you could have really, really good passive mobility. So if I'm moving your hip through different ranges and you're not doing anything at all, that would be our passive mobility. You could have really, really good passive mobility. I've seen it a few times, but the minute we try to get you to do it yourself, that range is like cut in half. And that's where that motor control comes in, because you have the capability to have the mobility. You just don't have the body awareness and the control to do it. And that's when it's pretty simple. Like, it just comes down to you training those muscles to have that control. And again, I should have mentioned this too, we're excluding like traumatic events. So like people who have sprained ankles, you're in a different situation. People who have had like ACL surgery or have torn their MCL or LCL, those are different situations than what we're talking about. Is there potential that lack of dorsiflexion could have led to your ACL or MCL sprain or tear? Yep, there is. There's a lot of good research that shows that. But we're not really going to touch on that. It's a bit of a different section. We're going to be talking more about that overuse aspect of how these repetitive things can kind of wear down the system, and how we end up developing pain in the knee when we have a sore hip. So yeah, so the appropriate motor control, if the glutes aren't firing properly. So what the glutes do, they stabilize the leg, they stabilize the hips. So if those aren't working properly, that again, just like that lack of dorsiflexion, causes the knees to go in. So if you're someone who is a weightlifter and you constantly see, and you're squatting, let's say, and you're looking in the mirror and you see your knee drift as you try to press up, you're not firing your glutes properly. It's kind of easiest way to say it. When that knee drifts, the glutes aren't firing. So you got to drive those knees apart, and then you'll notice like you're probably going to shoot up right away because those glutes automatically will kick in. But again, that's where that motor control of like, making sure that they do turn on and that they're turning on for the whole range of your motion is key. Yeah. And then when we find the next section, which is here, like when the hips are lacking that mobility, that's where we tend to see the low back come into play. This is the only time I talk about low back. This is our lower extremity jab. But when that low back comes into play, it's, again, like I said, usually because the hips are tight. They're not having that proper range of motion. So the big one that tends to be, we sit for the vast majority of our day. If you work at a desk, you probably sit for close to 6 hours consecutively throughout the day, which isn't great. It's not good for you. So getting up, taking those micro breaks, going for a walk, things like that are pretty key. From that, because we sit for so long, the hip flexors, so the psoas and iliacus, the muscles in the kind of that greatly impact your hip flexion, those get tight. They progressively get shorter because they don't need to be in a lengthened state anymore. They don't need to be in that position because the vast majority of your waking day is spent with them shortened. So now all of a sudden you have to stand up, you have to go run or do your thing, and you lose that mobility. So now the low back, which is supposed to be stable, is now the one that's creating that extension or creating the motions that should be coming from the hip, but your hip flexors or your glutes aren't allowing it to happen because, one, the hip flexors are tight and the glutes are weak. So that is kind of where a lot of the times the hip flexors, and so yeah, the hip flexors and the glutes play a pretty huge role in low back pain, and then also into obviously your knee pain, quad, hamstring pain as well. Okay. So this is where this is my fun stuff. I like rehab. Rehab's my favorite. Again, it's from kind of my background with personal training. I took a keen liking to this stuff. So
before we get to that, we do have one quick question.
Yeah.
Referring to your last slide, does a sit stand desk help?
Yeah.
For I'm gonna say the right, but to help with the tightness that you may get, or the functional misalignment that's going on, do those type desks help?
Yeah, definitely. I'm a big proponent. I think sit stand desks are great. Again, the big thing is it's coming down to like now the ergonomics of the sit stand desk. So it's like, if you're in a weird situation where the desk is too high, so if it's one that like is the peg system where you have to move it up, but if it's an electric one where you can kind of tailor to where you want it, then it's usually better, just because you have more control about the height of it. Yeah, like I think it's up to you. Like I personally can't, if you're someone who has to write, I can't write standing for whatever reason. It's not in my wheelhouse. I struggle with writing while standing up, but typing is easy. I don't know why. It works easier in my head. So yeah, it's just finding what works best for you, and then making sure like the computer monitor is at a good height for you as well. But yeah, I think sit stand desks are awesome. I actually just convinced a friend of mine to buy one. So yeah. So, but he has that at his office now, and he's loving it.
Great.
So it just depends on you.
Thank you.
No problem. Are we good? Keep going. Okay. So yeah, it's a foot and ankle exercises. Okay, cool. Foot and ankle exercises. I kind of lumped these together just because it's pretty much the same area. And at the end of the day, the foot being stable directly relates to the ankle being appropriately stable, yet still mobile. So passive toe spreading it's a really simple exercise. In reality, all of these for the most part are exercises you can do at home. If you have a band, great. If not, you don't really need one. But yeah, so passive toe spreading is pretty much, I don't have any, but those like the things you put between your toes that spread them apart. So if you go to like Shoppers Drug Mart, I think like people use them for like painting their toenails to like create space between the toes. Just like buy like a set of those and just like hang out for like 5, 10, 15 minutes, as long as it's like comfortable with those between your toes. And you'll notice that the feet will likely become more stable, or not, the feet won't become more stable, but you'll notice the toes start to splay. The traditional kind of look of like most feet is like the toes are like nice and tight together, right? If you see someone who, like an indigenous person from like South America, let's say, where like they are fully barefoot, they live in the jungle, like I don't know, though, but like people like that, their feet look very spread out. They're very, like, obviously they're calloused and things like that from not being able to do that, but the toes are spread. They grab the ground. They're able to do things with the feet that like you and I can't dream of right now. But if we could, again, train that back into the system, and buying wider toe box shoes can play a pretty big role. Active toe spreading is, again, just what it sounds like. It's trying to force your toes apart with just the muscles. So if this is my foot, my feet are like this usually, I'm going to try to spread my toes apart and then relax and then spread them apart again. So it's pretty simple movement. You can do that watching TV. In fact, I do it watching TV quite frequently, and it freaks out my fiance because she doesn't like feet. So that's one thing. The toe presses or toe curls with a band. So the press, all you have to do is just put the feet on the ground, and then you press the toes into the ground. So when we do that, that's activating those muscles along the bottom of the foot. So this is where those people with like a functionally flat foot will actually develop, they can start to train that arch to come back. So if you're somebody who lives in like orthotics, these are things that could be really, really beneficial for you long term if you're someone, if you don't want to be wearing orthotics the rest of your life. Yeah, so that's the toe presses. You can do the toe curls with the bands, which is the same premise, but you just have an elastic band, so like those big, like heavy TheraBand style, or a mini band, kind of whatever works best for you, or whatever you have available to you. You can do that. You can even do it into a towel. Like I said, you don't need a band, or just in the ground doing the toe presses. Towel scrunches or marble grabs. That's pretty much what it sounds like. It's just lay a towel flat on the ground and just work your way from the bottom, pulling the towel back towards you with your toes. The marble grab, again, just another way, make it more of a game. Try to pick up marbles with your toes. Start with a bigger marble and work your way down. See how dexterous you can get your toes. Again, one of a classmate that I had while I was going through school, was a big proponent for this, and he could seriously like pick up pennies off the ground with his feet. It was the weirdest thing, but it was one of his party tricks. So yeah, that's kind of things that you can look at, things that you can try. Yeah, just to try to help with those. So this is, again, so now the ankle stuff that we're going to touch into now, these are really for creating dorsiflexion. Like I said, most people don't have issues with plantar flexion, and maybe some. Those people tends to be from like the traumatic situation where like they sprained their ankle, something of the sort, or they had like an Achilles rupture. Those are the kinds of people that we tend to see the plantar flexion issues. So the pointing of the toe down. So yeah, dorsiflexion. These are the big ones. These are kind of the three that I'd like to talk about the most. So dorsiflexion, contract, relax. I'm trying to think. Do you guys want me to try to demonstrate these for you? I can move the computer around and we can kind of go that way. Or I can just talk these through. I don't want to show you my feet, so I don't want to show you the foot ones, but the ankle ones I'll show you.
The ankle visual would be a great idea.
Okay, let's do it.
Yes.
We'll all get up and stand and move around. You guys can try it too. Hopefully this doesn't go too dim. Actually, I might be able to do this just this way. Okay, so we got my table here. So the dorsiflexion, contract, relax is going to look a lot like this. So my foot's up here. Yeah, these are my slippers. So I'm going to lean into it, and then I'm going to press the forefoot into the ground. So I'm going to press, hold for 10 seconds. So we'll say that's 10. Then I'm going to relax the press, and I'm going to find that I'm likely going to lean a little bit forward. Okay. So again, with this one, you don't need to be up on a table. You can be just down on the ground, on a yoga mat, something like that. So I don't think you're able to see me on the ground. But yeah, so that'd be that one. So again, let's see here. I'll move you guys around. So it'd be like this. So knees back here, foot's there. I'm gonna lean in, press my foot into the ground. Hold, 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 hold. Relax the press and lean forward. Again, trying to keep the ankle on the ground. So if you are doing this at home, pop your slipper or your shoe off and lean into it, okay? One of the things that we can do to also assess for that is called the 4-finger drill or 4-inch test. That is just going, putting the knee, like putting the foot about 4 fingers from the wall and then leaning into the wall. You can also use this as a stretch. Okay, next one, the dynamic ankle dorsiflexion with a weight. So if I had a weight right now, I would put it on top of the knee. So if you have a kettlebell, dumbbell, even a big like 4-liter jug of milk, if you don't have anything at home, or like a couple cans of like big tomatoes, just hold on to that, a little bit of extra weight, just lean in, and you're just providing some overpressure. At the end of the day, you could just use your body weight and just press it. This is one where we do want to be standing up, just allows it to get into a little bit more comfortable of a range and we can press through. And then calf stretch on a step. That one just is your standard, like let the feet hang off the step. I don't have a step in my house, so I can't show you that one. So yeah, so we're just gonna have the feet flat, so the balls of the feet on the step. So we're gonna start up high and then we're gonna slowly lower down through that range of motion. I tend to like to say, make that range of motion last about 20 to 30 seconds. So from the top down to the bottom, 20 to 30 second stretch, and then hold it for about another 10 seconds at the bottom. Then just step off, step back up and repeat, usually about 2 to 3 times, okay? And again, stretches you can do daily. It's not a strength thing where you have to be worried that like you might overdo it. These are things that you could do daily pretty easily, okay? There we go. So knee, we have the banded squat. We got heel drop downs, knee extension, a single leg squat, and a lunge or a reverse lunge. So again, just things to strengthen the quads, things to strengthen the hamstrings, gonna be pretty key in just helping the knee stay stable so that it doesn't tilt inwards or anything like that. At the end of the day, if you come to the clinic and you have a knee issue, you'll pretty good chance you're gonna get some of these, but I'm also gonna give you stuff for your ankles. I'm also gonna give you stuff for your glutes. It's all related. So this is more targeted to the knee, but there's other things that I would want you to do either way. So yeah, banded squat's exactly what it sounds like. It's just doing a squat, but the knees are gonna have the band on the outside. So again, see if we can't really demo this one. I don't have anything here, but I would put the band, so a little like fit loop, I'd put it around here. So then I'm gonna step out, create a little bit of tension, whatever position is comfortable for you to squat, and then you're just gonna do your squat. So you're gonna squat down. Okay, so again, nothing too crazy. Any home care that I like to give out are things that can be done pretty easily with either bands that we give you from the clinic or things that are at least you would have around your house. Heel drop downs are again with a step. So you would have one foot on the step and then the other foot would come forward and you would just bend the knee slightly enough to allow the knee to track over the toes, creating dorsiflexion and flexion of the knee until the other heel taps down to the step below. And then you press back up with the opposing knee. So the one that's standing on the step. So again, we're working that quad, but what are we also doing? We're creating dorsiflexion. That's key. Terminal knee extension is mainly to target one aspect of the quad, the interior, like the inside. So the medial portion of the knee. There's a section of the quad there that is really important for helping to track the patella. So the patella being the kneecap. So and this section of the quad is called the vastus medialis obliquus. So VMO is what we'll call it. Where it sits. So if this is my kneecap right here, or here, I'll show you. Come here, Scully. So, oops. Okay. So let's see, rotate down. Okay, so quad sits right here, right? Front of the thigh. Vastus medialis is going to be on the inside. So it's right here. That sits down. So if you see like weightlifters or cyclists are a big one, they always have huge quads. So a cyclist, like a professional cyclist or like the Tour de France style guys, that VMO, so right there, tends to be massive. It looks like a big teardrop. That allows the patella to track really nicely and it stabilizes the knee medially. So if we are someone who has had some trauma medially or who has like that overuse injury coming from the hip or the ankle, and they're getting pain in the medial knee, but nothing's ever happened, they don't know why, there's a good chance that that VMO is weak because it hasn't been able to counteract that valgus force, so that caving in of the knee towards the inside of the body. So yeah, that's that'd be the terminal knee extension. So that's, again, one, you just have a band set at the back of the knee and you would let the knee bend forward and then you press the heel down, forcing that middle portion of the quad to really, or the medial portion of the quad to really activate. It's a burner too, especially if you are someone who just wants to work it into your workout schedule or something like that. It's a fun one with a band at the end of your workout. Yeah, and then single leg squat, I'm not going to try to demonstrate that one. I'm working through some things with my own mobility, and it would just be bad. But yeah, it's exactly what it sounds like. Do a squat on one leg. It's one of like the key movements of being able to perform these movements really well is a single leg squat. You can see people who squat like absolutely beautifully with both legs, and then you get them to squat single leg and it's a travesty. But yeah, that's where we find, like, again, we're looking at those things and trying to figure out how to make it better and how to go from there. Yeah, and then lunge, reverse lunge, again, we're forcing with those, we have to have that dorsiflexion. So we're forcing it, we're training that dorsiflexion there. The hip has to be stable enough to not allow the knee to cave in. And we're training the quads. So it's the single leg squat particularly, and that reverse lunge or lunge are probably the two more advanced, especially on this page. So not ones that I would want anyone to jump into right away, but they are things that we do use to evaluate people in the clinic if we need to. Alrighty, so hip exercises. So we're looking at motor control. So this is the one where we want to make sure that we're creating that appropriate stability and we have the ability to move the joint in those ranges of motion. So these are going to be more so like strengthening and controlled things like that. Our mobility, actually in reality, hip cars down in the mobility section falls into both motor control and mobility. It's a lovely exercise that just does a ton. So yeah, we'll touch on that in a second. So motor control, banded glute bridge. So just doing a standard glute bridge. So we'll be laying down on our back, knees up, kind of 90-90 position. We'll put a band just above the knee. We're going to create a little bit of pressure outwards against the band. And then we are going to thrust through, hold for 3 seconds, and drop back down. Let's see if I can do a quick demo here for that one. And we'll do, so yeah, clamshell. Again, similarly, I'll talk through these and I'll do a quick show of what they would look like. So yeah, clamshell, you'd be laying on the side. Again, knees at a 90-90 position. So that's so the hip roughly 90 degrees and the knees forming a 90 degree. That would be what I mean by 90-90. So yeah, there, again, band around just above the knees. We're gonna lock the heels together and then we're just gonna press the outside of the knee open, squeezing that through the glute. Again, allows the glute med to really activate. Banded squat, that band press outwards is forcing those glutes to work even harder. So that's why this is also here. So again, another example of where we see the banded squat is creating dorsiflexion at the ankle if we're squatting properly. It's training the quads to contract to allow it to go through the movement and the hamstrings to stabilize the movement. And it's also forcing the glutes to work to do their job. It's another example where one exercise can target the whole lower extremity pretty easily. Single leg deadlift. This could also be something as simple as like a hip airplane or a hip opener. It's just a motion of going down like you're doing a deadlift, but this one's without like the knee bend. It's more so just kind of creating like a pendulum almost. Again, I'll do a quick demo of these ones too. So yeah, those would be the motor control. I'll do a quick demo of the glute bridge, the clamshell, and the single leg deadlift, and then we'll go into the mobility. Trying to see. Okay. So banded glute bridge, it's going to look a lot like this. So I'm going to be up here. So this is my bed. So knees are up like this. So this is our 90-90 position at the hips. So I'm going to have a band set right about there. So it's going from this leg to this leg, looped around. So I'm going to press outwards into that band. And then from there, I'm going to brace through the abdomen, find a nice neutral pelvis. And I'm going to squeeze upwards, holding that for 3 seconds. 3, 2, 1. And then we're going to lower down. Okay. So pretty easy exercise. Again, something that can be done super simply at home. That clamshell is going to look just like this. So we're up like this. So this is what I mean, heels locked together, knees at 90-90, band right here. I'm going to keep that heel locked on that other heel, and I'm going to press up. So when I do this, my glutes activate. With a band, you'll feel it even more, and then opening through. Okay, that's that one. And then single leg deadlift would be just like this. So if let's say I'm doing it from my left leg, so for you guys, it'll be the easiest to see. Right leg's going to come up just slightly. It can stay straightforward. It doesn't matter. Right hand's going to be kind of our balance. If you're doing these weighted, then hold the weight in your right hand. So we're going to start here. So I'm going to bend down, hold, and pull through. So what we're looking at is to try to avoid that knee waggling. Obviously, like it's pretty tough. My knee was wobbling in there. Again, this is one where being barefoot is going to make it a lot easier. And more beneficial to train through that range of motion. Okay. All right, so yeah, mobility. This is where we're gonna get into that hip flexion. And then, yeah, so lunge with hip flexion stretch, pretty simple one. But again, this actually in reality covers kind of both hip flexion and extension. Your forward leg will get a pretty deep flexion, and that's what we're focusing on. But good chance you're going to notice that you're stretching in the extension component on the back leg. Hip 90-90 with external and internal rotation stretch with extension. So we'll show you that one. Hip cars is a huge one for mobility and the motor control. And then world's greatest stretch is just a stretch that if you do anything active or you're a runner, you should probably do it. It kind of covers the whole gamut of things. And the first portion of it, or one of the middle portions, I guess, sorry, is pretty much the lunge with hip flexion stretch. Okay, so we'll jump into those here real quick. Okay, so lunge with hip flexion stretch. Let's see here if I gotta be on the ground for this one. So left knee forward, right elbow is gonna come inside left knee forward, left elbow is going to come inside my left knee. Okay, so my right hip is back. Move the chair. A little bit better. So as I lean in, I'm going to press my torso down and try to push my elbow to the ground. Okay, so this hand can come out, stabilize myself on the ground, and I'm going to reach in. So when I do that, I feel a pretty deep stretch already in that hip flexor in the front, trying to create that hip flexion. So you're going to feel that a lot of through the hamstring and in through the glute. This back hip is going to get a bit of a stretch through that hip flexor. It shouldn't be what you're feeling the most of though. If it is, we need to work on things, but that's just things that need to be worked on. Not the end of the world. So yeah, we're going to be here, leaning in and creating that flexion. And again, what else are we kind of seeing here that's happening with the knee over the toe? We're creating more dorsiflexion. Again, another thing that I've kind of feel like I've been beating the drum on that one a little bit we need to get that dorsiflexion. So yeah, another one where we can get that. Hip 90-90 with external and internal rotation and the extension. This one's a little wonky. So we're gonna get into a bit of a weird position. You guys can't see that. Hold on, give me a second. Okay. So this hip is externally rotated. This one is internally rotated. So what I'm gonna do from here, I'm gonna rotate back towards my right foot, which is the internally rotated leg. Then I'm gonna rotate forward. As I rotate forward, I'm pressing this knee into the ground, pressing through. And as I get through, this hip is again coming forward, and I'm leaning in to create that extension stretch on the back leg. So one of the ways that we're getting that more extension stretch with that one is we're widening our stance. So when we widen the stance, especially if we're doing that with like the lunge for hip flexion stretch to this one, that having the knee closer, like the back knee closer to the front knee, is going to create more of a hip flexion stretch on that front knee. Having it further away is likely to create more of a stretch on that back leg. So yeah, something we can look at for there. Okay, hip cars. I'll move this over here. So again, like I said, you can do this one standing or kneeling. I'm going to use Scully here for some balance. Again, recommend using something for balance if you're doing this standing. So what we're going to do, we're going to lift the hip up. We're going to externally rotate the hip. Then we're going to internally rotate the hip. Now we're going to do a hurdler aspect. So we're going to pull the leg back and around, straight through, back. We're going to internally rotate the hip first this time, then externally, and then pull it back around, just like that. Okay. So again, standing can be more difficult because you kind of have to be able to brace and control the whole movement. But whereas like the kneeling component, it just looks more like you pull the knee forward, you go through your range of motion and around. So it's a little bit better to be more of like a beginner one. So that'd be kind of where I'd start. But some people really struggle with the kneeling, but they can knock the standing out of the park. So just see what's best for you. World's greatest stretch is, so again, this is one I'll show you here. So like I said, that hip flexion stretch is kind of the first part of it. So if we're here, wow, I'm right under the light. I look like a ghost. Okay, here we go, step out of that. So we're gonna pull the leg up, get that big hip flexion. From there, I'm gonna step forward. And now this is where we see that similar stretch. We're gonna lunge down and turn. And then this one's gonna come through and back up. You'll find some where as they go down, they get into that position and then they rotate up. That's another aspect of it. You don't have to do it that way. Some people say that's how to do it. Some people say that's not how you do it. So just depends on what you like. It's not a bad thing to work in some thoracic mobility while you do kind of any exercise. But yeah, that is all of the exercises. So yeah, that's the fun stuff for me. And then yeah, how AST can help. So when you come into the clinic and like you come to see us, we're going to take a pretty in-depth look at all of this stuff. We want to see how you move. We want to see how you're going through things, just to see if, or see where your kind of limitations are. And yeah, that's kind of what we would do if you came in. We were going to do some soft tissue work. So that's where like the active release and things like that can really come into play to promote that optimal mobility of the muscles. Because if the muscles is too tight, it's too shortened and it's not able to lengthen, the ART or the soft tissue work is going to allow that to happen really nicely. Then we can obviously, especially with the chiropractors, we can work in the joint manipulation. So a lot of people think like joint manipulation or adjusting is only for the spine. It's not. We can do it to the ankles, the hips. Yeah, so kind of work our way through. Yeah, so joint manipulation to ensure adequate motion within the joint. So yeah, especially if it is a little locked down, it's more of a hard stop within that joint. We can work the muscles and we can get in there, loosen up that joint that way with a quick adjustment. And usually we're we're laughing after that. And then it's training you on how to go from there. So that's kind of where this next section is provide those specific exercises to you that are going to help you achieve your goal. So as much as like everything I've given you, there's a good chance you'd get a good chunk of these. If I feel like you need to work elsewhere with other things, or more so, we need to work on your work more so on like your lumbar stabilization, your low back stabilization. We might work into those before we get into other things. A lot of the times these issues tend to be like the chicken or the egg type thing. But at the end of the day, the chicken and the egg in this case doesn't really matter which came first. We just have to address them both. And if we're missing one, there's a good chance you're going to have the same issue again. But yeah, that's just kind of some things that we can do. If you are in a situation where you have had that like kind of traumatic, hit the wrong button. If you have had that kind of traumatic aspect, or you've had that situation where the overuse injury has finally caught up, then you might be a person where like laser could be really beneficial, or the game ready for like that cold therapy to decrease the inflammation during the acute stages, just to kind of help with healing. So yeah, the laser just helps to promote the healing if there's an active injury as well. So yeah, that's pretty much what AST will do and what we can do and how we like to help everybody. Yeah, that's pretty much all I got for you guys. That's any questions? I see we have some stuff written up here. So
yes, we do have one question. I'll just read it as it was written. I've been hearing some info about icing not being the thing to do. Are you familiar with any of this research?
Yeah, so there is a bit of that. So kind of the best. Okay, so ice, in my opinion, does have a bit of a place. If you have a quick, if you just, let's say, rolled your ankle, at the end of the day, we do kind of want to decrease a little bit of swelling. I don't think you should be taking anti-inflammatories. That turns off the inflammation system. Ice, a little bit of compression, doesn't turn it off, it just limits it. We want to control how much inflammation we're getting, because that's going to be what is going to be a big limiting factor on our range of motion. So especially with an ankle per se. Your most important thing though, if you have an injury, so again, I'm going to use the ankle for example, because everybody rolls their ankle at some point in time, it seems. You want to maintain that range of motion. So just doing simple ankle pumps and like moving the ankle around, so putting the ankle into dorsiflexion and plantar flexion, a little bit of inversion, eversion, probably not those two to start, just because that's more than likely the way you sprained your ankle was an inversion sprain. But using that plantar flexion, dorsiflexion, pumping the ankle just to keep mobility, that's going to bring blood flow to the area. That's going to bring lymphatic tissue to the area to help flush everything out. But at the same time, tossing a little bit of ice in there like isn't the end of the world. Now, do I think the first thing you need to do is put ice on it? No, I don't. I think you need to create the mobility, but if it's really sore, using a little bit of ice for like a pain management isn't the end of the world, in conjunction with allowing it to decrease your inflammation a little bit, or control inflammation, I should say, not necessarily decrease it. Did that answer that question?
Yes, I believe. Sorry. Yes, I do believe it did. So just to summarize that, would ice be more to control the pain without, say, something like Advil or an anti-inflammatory? It's just kind of really used to control pain, not actually to help in any healing processes. That kind of
ice
interpretation
ice,
of that.
Yeah, for the most part. Ice definitely does not promote healing. There are a lot of things that, as I think the question said, like ice can be a delaying component in healing, which is why we want to control the use of ice. If you're sitting with ice in your ankle for like 24 hours, that's excessive. Don't do that. But working it in there maybe like for like 10 minutes, every couple hours, just to stop that ankle from being like this to that, I don't think there's an issue there. Using tensor bandages, don't think there's an issue with that. Just like, again, with that compression, it allows the ankle to stay small, or to just keep its shape. that's kind of where research is trending. But yeah, it's
Great, thank you.
It's tough. One party says heat, one says no heat, one says ice, one says no ice. They just keep contradicting each other. So I don't know.
Do what makes you feel comfortable in that circumstance. I'm just trying to visualize putting a foot in or an ankle in without having ice, and that that definitely does help with the inflammation. Are there any more questions that people could pipe on and ask themselves, or write into the chat box? I'm getting a lot of thank yous and well done, Dr. Kurt. I might take this time to share with the group that Dr. Kurt is actually available for private workshops. Do you mind talking a little bit more of what you would offer for your private workshops? Are they specific to soccer teams or say volleyball clubs, or content like what you've done tonight, or is it a little bit more active, like a workshop where people are learning?
Yeah, it can
movements.
Pretty much be both. If it's more so like if the group wants to kind of get a better understanding of how things occur, or like how injuries kind of happen and those types of things, we can definitely make it more of like this type of thing. Or if people want that kind of full experience of like taking people through, kind of correcting things, then yeah, it would be more tailored, not as like a clinical aspect where we're going to be like doing an evaluation on each person, just because that does take a fair amount of time, but just looking at kind of showing them some basic stretches where we all go through those stretches, or we all go through that strengthening together. Maybe things like that as well. It's really whatever the coaches, parents, and people want, or even just whoever wants it. It's easy.
Okay, great. So do consider that if any of you are a coach or on a soccer team, volleyball team, what have you, gymnastics. Yeah. I know I have a daughter in gymnastics, and watching the range of motion in her hips is rather incredible, actually, because they're so young. That said, there is one more question. Do you have a PDF with the exercises? I'm going to touch a little bit on this. There is a way to review this Zoom call on YouTube, which I will be sending a link out probably within the next 24 hours. So you'll be able to find the visual review of those exercises. Will you be providing any PDFs with that for the follow-up email, Dr. Kurt?
Yeah, we can definitely put together a PDF. That's pretty quick. We can do that, no sweat. What I would also like to mention is I'm hopefully getting together with kind of my video person who does all my personal videos for other things. And we're going to go through all of these and kind of put together a full video of like the hip and the ankle and like how to actually go through everything and how to do the motion itself, just as we kind of talked through here, but it'll show it a little with better angle and like with movement around me, so you can see exactly what I'm doing, and not in slippers on my laminate floor where I'm slipping. So yeah, but yeah, so it'd be more like kind of gym appropriate and be a bit easier to kind of see things. So I'll hopefully be putting that together within the next week, and then if anyone is interested, we could, I'm sure between Renee and I, we can just get that distributed to everybody who registered, whether or not that's through like some sort of Google Drive or a like Dropbox type thing. I don't know what we could use there, but I'm sure we could figure it out.
Okay, great, thank you. Another question, would you do a private session for an office group?
Yeah, definitely. Yeah, it doesn't have to be athletes. Just give me an idea of kind of what you're looking at and what you're thinking, and yeah, I'd be up to that as long as you guys are.
Okay. And I think I had mentioned that there will be links to how you can register for these type of sessions. We actually have it up on the website under the events where you likely signed up for this Zoom. And that will start the conversation with Dr. Kurt. I'm always here to help organize things if you need that extra hand as well, Dr. Kurt. Any more questions? What a great session. I learned a lot. Things I never thought about, the ankle is mobile, the knee is stable. Mine, not so much at the moment, but something to think about. I think we can sign off. Thank you so much, everybody who joined. Thank you, Dr. Kurt, for all your great information. Stay tuned for any upcoming events or lectures that Dr. Kurt and others at AST will be doing. We always have lots of fun content. If you have any thoughts or ideas, maybe like an office specific movement lecture, those are lots of, we always look forward to the feedback to hear what the patients want in the group as well. So yes, thank you so much for your time. And while I'm going to stop rambling and sign off, Dr. Kurt, have a great night.
Thanks.
Everyone
Take care,
else,
everybody.
take care. Yes, bye. Thank you.